Good morning, everyone. Thank you for joining this morning. My name is Christina Kenzie. I am the Assistant Coordinator of Neighborhood Services with the Department of Senior Services in Erie County. Welcome to our virtual 2020 Elder Law Day Summer Series. This series will run every Wednesday through the end of this month, September. Please visit erie.gov/ELD to register for upcoming sessions. Please feel free to use our question and answer box to the right-hand side. The speakers will be answering questions throughout the presentation. Please refrain from adding any personal information into those questions. This presentation is being recorded, so you will be able to access it at a later date, and the PowerPoint will also be available on our website. I'd like to take a minute to thank those individuals who have helped make this summer series possible, including our County Executive, Mark Polenkars, Karen Nicholson, the CEO for the Center for Elder Law and Justice, and our Senior Services Commissioner, David Shank. Please allow me to introduce our guest speakers. We have Dr. Kathleen Grimm, a clinical associate professor of medicine and currently works as the Director of Supportive Care and Palliative Medicine at ECMC. She has lectured and presented locally in national forums on the role of community health workers as members of integrated health teams, the social detriments of health, the Conversation Project, the role of mercy doulas at the end of life care, and equity in care access. We also have Sandra Lauer. Sandra has been a registered nurse at ECMC for 19 years. Her current role is in the Supportive Care and Palliative Medicine Department as a Continuum of Care Director. She's also a member of ECMC's Embrace Your Values Community Outreach Team. Welcome, ladies.
Thank you.
Just make sure you turn on your video, Sandra.
Thank you so much, Christine. Thank you for that kind introduction. I'm Dr. Katie Grimm, and I cannot tell you how much we very much appreciate. I speak for my friend Sandra. I think we speak for each other often because we work together so much. That this is a project that we're very passionate about, and so always welcome the opportunity to present the work of the Conversation Project and the work that we've been doing here at ECMC for a few years. I'd like to introduce it for those who may not be familiar with it, because I think I make the assumption, because I always work so closely with these projects, that I forget that it may not be known to everyone in the community. So the Conversation Project started as a national media campaign, a social media campaign by the woman whose picture is here, Ellen Goodman. And for those in the audience who may have gray hair like I do, you may remember Ellen as a Pulitzer Prize winning journalist with the Boston Globe, who wrote wonderfully about many, many issues at the time, women's issues, but also was very much a progressive thinker and very activist in many causes. The one thing that impressed Ellen, though, was when she went through her journey with her mom. Her mom struggled with Alzheimer's dementia, and she was, as many daughters might be, sons and daughters, was her mother's healthcare proxy. So and later on, we'll talk about what that means and what a proxy voice actually means for and what the role should be of the proxy. But Ellen, as the proxy, was then tasked with speaking to the medical team and to the team that talked to her about her mom's care, about interventions, about what should be done and what her mom may have wanted. At the end of her life, when her mom went through dementia, died from dementia, which, as we know, is, the number, I think it's number 5 leading cause now of death in the United States, many people with dementia, and it is a terminal illness. So it's a long process, but it leads to death. Ellen, at the end of her mom's life, said, and she shared with many people, that she was absolutely blindsided, that her grief was intense, but more importantly, her guilt was intense, because what she shared with many people is, as informed as she was, as knowledgeable as she was, and what she saw herself as someone who had good health literacy, is she was blindsided because the one person she had never spoken to about what was important and what would be important at the end of life was her mom. So she was making these decisions based on what she thought was right and thought what would be what her mom wanted. So Ellen,
We're having a little trouble hearing you. I think that there may be some with your audio or your internet connection.
is that any better? No?
Yeah, I think it's the internet connection possibly. It's going in and out.
Oh, darn it. That's too bad. I'm not sure. We'll try to fix that, but I guess we'll just keep going, Christine. Is that okay? So should I
Okay, try again now.
how's it sound now?
Good. It was WebEx, I think, having some internet connection. So
Yeah, they may be. Would you like me? I'll just pick up where I was then. Yeah. Okay. Thank you. So Ellen Goodman, who was working or still works, I believe, and lives in Boston, had many, Sandra, my colleague Sandra always likes to call them fabulous friends, like Dr. Atul Gawande. And anyone who knows Dr. Gawande or knows of his name knows that he wrote a book called Being Mortal, which was his journey in understanding these conversations and the process with his own father as his father was going through a terminal illness. So Ellen began talking to these friends, and all of them agreed that when they looked at the process of terminal illness and death and dying, what separated good deaths from bad deaths, or what separated actually guilt and terrible guilt, and grief always happened, but the guilt piece was so much more relieved when there had been conversations. Not necessarily conversations about what direct interventions people wanted, but conversations based on what was a person's values, what was important to them, what mattered to them, how would they define a good day. So they got together and they created this conversation project, which is it's a social media national campaign. It's not an ECMC campaign necessarily, but we picked it up very quickly because, as anyone listening recognizes, we work in a trauma center. So there was always this idea that end of life was something that people had time to prepare for, could prepare for, and maybe many people do. In chronic illness, you may have ups and downs and be able to talk to your family about what's important to you. But in a trauma center, we often see people that are very suddenly faced with sudden circumstances that they may not have been prepared for. And our favorite question to anybody in the community is, when we go out to the community, is what do they feel is the number one trauma we see at ECMC? And many times the answers, are what you might expect. People say, well, car accidents or gunshots. And we always say, no, the number one trauma here is falls, and falls often in our elderly population. And so we have stories galore, and I'll just share one just to maybe illustrate why this became an important project to us. Is we have many 80-year-olds, 70-year-olds, even 90-year-olds that are living independently in the community. And they may have had conversations with their doctors, with their families, saying, if I'm in a situation where I'm hooked up to machines, please don't keep me going. And they may have just started these conversations. But often what we see are people that are 80 living their life and doing, things that families wish they wouldn't do sometimes, but getting up on the ladder to clean out the gutters and falling and either bleeding into their head or having a fractured neck. And then in a situation where the family there may be at the bedsides trying to decide what would be important to this person if they could not wake up again, if they could not be aware of us at the bedside. And so that began, I think, our real journey in the Conversation Project. As you see at the bottom of your screen, the Conversation Project has a website, and they have wonderful tools and talking kits that anyone can access. So the Conversation Project we took on and renamed as Your Voice, Your Values, because we really wanted this to be about value-based conversations. Although medicine and doctors, and I'm one of them, always come at patients and families and want to know, what do you want? What's the intervention? Here's what I can do. What we're hoping from the community is that the community begins to talk to them, to their children, to their relatives, to their spouses about, here's what a good day for me would be. Here's what's important to me. Try everything, but here's what I want you to remember about me, that this is what's important. So in a trauma center, we realize that it's not just about the elderly or the sick, because sudden events happen and sudden death and sudden trauma happens. So even our young and healthy individuals, and the Conversation Project actually, interestingly, has a whole arm where they're talking to college students about, it's important that they talk about this as well. And it's not meant to be morbid. It's meant to be how people define their own self, how they define what is important to them. So it's planning for your future. And it goes through different parts of your life. You know, when you're young and in college, financial planning may not be important, but then things change as you move through life, and you may get married, you have a family, and as you get sicker, all these things change. So everyone is really encouraged to do financial planning, and what we're trying to link it to is doing some planning about how to live the remainder of your life, no matter what you may be facing, no matter what the circumstance is. So the Conversation Project to us is part of wellness. It's part of really a package that should be part of every piece of taking care of yourself. And we know from research how incredibly important this is. Many, many, many surveys have shown just what we're showing on the screen, that 90% of people, when you ask them, they'll say, oh yes, it's very important that I talk to my family about this. I know that's important. But only a third of people have done the talking, because these are hard conversations to initiate. And we always encourage at the end of our talk, anyone listening to go home and say, hey, I heard from these trauma guys at ECMC, and it's not just about if I get cancer or dementia, but what if I'm suddenly in a situation? I just want you to know what's important to me. So more than 9 in 10 Americans think it's important to talk about their loved ones, to their loved ones, about their own wishes. And the Conversation Project has framed it around end of life. We like to just say, talk about your life, talk about who you are and your values. It's so, I think I've said this, but just maybe to emphasize that it's for everyone. Of course, more importantly, once you start moving through chronic illness, and once you and your family are facing decisions, perhaps then it becomes much more important to be really intentional about it. But at least people should talk about it all through their life. The starter kit is on the website. It's very accessible. So interestingly, there's videos on the website too, and you'll see Ellen Goodman making the point that if you have this toolkit in your hands, it makes the conversation easier to start, because you don't have to think of the words. They're there for you to try to initiate the conversations. They don't need to be perfect, because you may have to move through several conversations. It's not just one, it's many conversations as life changes. And we know that not everyone wants to have these conversations. The community always reminds us that there's many, people that want to have these conversations with the people they love, and their love immediately turns them off. So I always encourage people to say, well, think about us when you may try to start it, and remind people that it's not just about these terminal illnesses. Think about being in a trauma and not having your voice, and make it important to have your family know what would be very important to you. And we see this every day in our trauma center. We do, young and old, people in every unimaginable sudden circumstance. It has a major impact, not just on the healthcare delivery system. Doctors feel better when they know they're giving the care that the patient would want. I always remind people that it's not about unnecessary care. Care that's given is always necessary. And we have an unimaginable, we in medicine, toolbox of things we can give to people. But I think what COVID has shown us in particular is that even when we know that we can do all these things, what we want to be sure of is that we're not giving unwanted care. Care that 82-year-old man who may fall and bleed into his head and may never be able to wake up and may always be unaware of his family being at the bedside. We want to know that the caregiving aligns with what his values would be. And COVID, I think this is more important now in the COVID era than ever before, because we faced in March and April in particular many circumstances when families had never had conversations and were in very sudden, very urgent situations. So the famous line that the Conversation Project uses is, it's always too early until it's too late, always. So I'm hoping, I'd like to share a quick video if it'll pop up well for me, just maybe to emphasize this, because this is a national conversation. So it's been on television. And so I'm hoping you can watch Diane Sawyer with me.
Wants to join you in something right at the heart of the American family. How we can all help the people who care about us make decisions near the end of our lives. And 9 out of 10 of you have told us that we should all be talking about it at all ages, what we want. And yet only a fraction of us have done it. And we know it makes a huge difference in the health of the caregiver as well as those cared for. So ABC News has taken cameras inside a vital, loving family, part of a new community, deciding to have a conversation. This is 85-year-old Norm and his daughter, Maureen.
My dad is 85 today. He's still very, very active. He's a wonderful friend.
Throughout life, daughter and father have always talked about everything, except one thing: how to control the end of your life in the same way you control the prime of your life. So dad and daughter gather the family together, 3 generations, for an act of love.
And so now we're just asking that you share some of your thoughts about what you would like at the end of your life, so that we can honor your wishes.
We are part of something new underway for families in America that says having the conversation is a gift parents and children give each other. And there's proof of the difference it makes. Studies show depression rates plummet after a loss if the families have had the conversation. Renowned physician Dr. Attila Gawande says doctors and nurses see it firsthand.
When you're there in that moment and you're talking to the family and you're saying, how much will it bother your father if he ends up this way? And they say, more often than not, I don't know. We never talked about it. That it is incredibly traumatic for the family, for the doctors involved. There's often conflict. It can tear families apart.
So Dr. Gawande has become part of a team led by Pulitzer Prize-winning writer Ellen Goodman. It is called the Conversation Project. It is a kind of guide for families looking for a way to begin.
If we give them a way to talk about it and give people something to hang on to when they're afraid to start this conversation, they can do it and pass it on.
Families like the Jennings. They looked over the conversation guide before they sat down together. First, there's laughter.
Oh, my golf swing's still good.
And then Dad directly eases his daughter's guilt and worry about having put their mother in hospice.
I felt like that meant we were giving up on Mom.
She was in a lot of pain, and I think it was handled really well.
And next, Maureen asks her dad for clarity on what he considers a good end to a great life.
So if you were in a condition where you couldn't make decisions for yourself, how extreme would you want us to take measures to save your life versus letting you go?
Well, I think I'm ready to go anytime. You know, I wouldn't prolong anything. I mean, I've lived a great life. Pretty lucky. And because of you guys, you know.
Unexpectedly, a grandson is inspired to speak up about his own wishes for his own life.
That if there was no meaningful communication, that I would want you to stop trying to intervene.
We're not ready for you to go that soon.
Well, we're not ready for you to go that soon either, so.
One by one, the others weigh in, all ages.
Happy birthday!
And with that, another family has joined a kind of estate planning for the heart.
Go.
The conversation beginning in America. So please tell us your stories in the days ahead about
Oh, sorry. So, I every time we show that video, and that is on the website if you ever want to access it. I think each time it strikes me how the father that they're talking to says what I hear often, which is, I just want to live. And I would say, of course, that is not our point in this conversation. Life is not something that anyone wants to end or talk about ending. But what we really want to understand is, if we're faced with that circumstance, help us to understand what is important to you. So advanced care planning, Joanne Lynn is a doctor who practiced geriatrics. And she says it's really about planning for the what ifs. What if any of us were to leave here and something sudden were to happen to ourselves or to someone we love? Would we have information that they've given us about what would be important to them? So I'm going to turn this over to my friend Sandra, who's going to take you through, I'm sorry, and this is just what's on the website, just a quick glimpse. So please go to theconversationproject.org to get the toolkit, to get all the information, to watch some videos, and maybe get a start and some comfort in how this might work for you and your family. And my friend Sandra will walk you through maybe some of the important points of what a proxy voice is.
Okay. All right. Thank you, Dr. Grimm. Good morning. So as Dr. Grimm said, on the website, which we hope you'll go in and access and see all of the resources that are available there, including this toolkit, which is Who Will Speak for You, How to Choose and How to Be a Healthcare Proxy. And it's very self-serving that we do a lot of this community work because, of course, we're here, and in my 19 years of being here as a registered nurse, I've met people so many times in crisis, and families standing at the bedside of somebody who, let's not misunderstand, these are folks who are so ill or so injured, they're not able to speak for themselves. They can't say, oh, this is how I would want to be cared for, or this is what matters most to me at that time. And so we're turning to their family members. And as Dr. Grimm, kept reiterating, if you've not had these sort of foundational value-based talks about, if something were to happen to me and this were the situation, I would want to be cared for in this way. And so the Conversation Project recognized that these conversations can be very difficult. People may not know in advance exactly, would I want a feeding tube? Would I want to be on a breathing machine? Because again, if you're so ill or injured that you don't even know the situation of what's happening, it's the folks around you that will be talking with the doctors and helping them understand what would be most important to you. We had done a presentation some time ago for a group of financial planners. And in advance of that, I was reading some things and I found this great line that I just love. It said, more important than a well-executed document at the bedside of a person who can't speak for themselves is a well-informed family member. So we at the hospital, again, we love to see when people come in with an actual document, a healthcare proxy or a living will or something that provides some guidance. But quite honestly, again, if those pieces of paper come in to us and there's been no foundational conversation with the people who are going to show up around your bedside, it just creates more grief, more anxiety, more fear, more worry, and a lot of conflict. So I know that people, and probably in general, when we go into the community, and I bet folks that are on this call today are very self-advocates and gone to attorneys or created documents or looked online and really done a lot of this work. But just remember, if you've done that, even people who go pay money, go to an attorney, create documents, put them in your underwear drawer, wherever you keep your important documents. And then it's only when you are so ill or injured and can't speak for yourself that those documents come out. And then we're trying to interpret what was meant by that. So the Who Will Speak for You is a very important document because, again, on the flip side of that, I've been there where we do have the healthcare proxy. We contact the person that's listed. They have, number one, no idea that they were named as the healthcare proxy. They have no idea what it entails. They think it's about the money. They think it means they're a power of attorney. And so if you give somebody that agency, they're actually making decisions for you regarding really life and death. And if you haven't given them information to use in decision making, you've really created, again, a lot of anxiety and fear for people. So that being said, we don't twist arms to get people to create healthcare proxies, although the healthcare proxy is, while you have your voice and you're able to, it is your decision-making ability to say, this is the person I most trust to be at the bedside and helping to make decisions for me in the event that I can't do that for myself. Honestly, it's the only advanced directive that I have. I don't have anything else that lists any of my care treatment preferences because, again, I don't know. I mean, I try to do advanced care planning to think about what if, but I have those conversations with my healthcare proxy and try to give her that level of comfort that if, I hope not, but if that should happen, that she would be in that position to represent me. So if you don't want to create a healthcare proxy, that's okay. But we just like to share with people in the community, then how would we at the hospital, if you should come to the hospital, unable to speak for yourself, how do we know who to talk with about your care treatment? So New York State actually gives us a list that we have to follow legally. And this is, again, for people who do not have a healthcare proxy, that cannot speak for themselves. And this is who New York State tells us to speak with. So the first person on the list is a legal guardian. So this is somebody who has been taken to court and a judge has deemed that the person doesn't have capacity to make their own healthcare decisions. And so we talk with that person about how to care for them. But not too many people have legal guardians. So the next person would be a spouse, or they added in 2011 something called the Family Health Care Decisions Act passed, and they added on that same list a spouse or domestic partner. And that was for, at the time, same-sex couples who couldn't get married, people who had been in long-term relationships. They either had children together, they were engaged to be married, or financially enmeshed. So we'll say that some people have neither of those, and sometimes people have both of those, which can be a little messy. But and so we try to figure out who the person is. And just remember, these folks on the list, we can't make them, but we have to approach them. If they're engaged with the patient, we have to go to them and say, are you able and willing to make healthcare decisions with the doctors for this person? So if you don't have a spouse or domestic partner, or they're not able to do it, then it's adult children. And actually, it's all of the children that we have to go to. So I've been involved where there are 15 children, and we're trying to reach out to each of them. And we try to identify one person that would feel comfortable and confident to take that role on. But oftentimes we're having a lot of family meetings to try to get kids on the same page to try to identify what would be most important for their parent. If you don't have adult children over 18, then it's your parents, and that would be both of them again. And if your parents are, predeceased or not able to, then it's siblings. And again, that's all of them, not the smartest or the nicest. It's all of the siblings. And we're again trying to talk with folks to identify who would be the best person to represent. And then if they have no adult siblings, then it's close friend, which could be another family member, a cousin or an aunt or an uncle, or it could really be a close friend. We've had it where it's been the landlord for somebody that was close to the person. And what's not on this list, but we maybe see a disproportionate number at ECMC, is folks who have nobody on that list. There is nobody to represent them. And so that case, it's two physicians in the best interest of the patient. And we have an ethics committee that weighs in on that to see that we're acting in the person's best interest. So I would say, think for yourself. And if you still, if you are happy with the person or persons on the list that New York State would want us to speak with, that's fine. Then we would encourage you to still go on the Conversation Project website and have ongoing conversations with this person or persons. But if you are not happy, which I was not personally happy with who New York State wanted, so I had to complete a healthcare proxy and name the person that I wanted. And again, importantly is that you would then share that information with the people on this list so that they would know why you chose the person that you did. Because oftentimes that can cause hard feelings too, is why wouldn't my mother have chosen me? Why did she pick my sister? She's terrible. And so it's really about having those conversations up front to relieve people of some of those stressful feelings if a crisis should occur. So oftentimes people are confused, understandably, between something called a MOLST and an advanced directive. So this little chart here helps us understand MOLST is medical orders for life-sustaining treatment. So just as the name indicates, it is a medical order. So if you look at under the characteristics of who would have a MOLST or who would have an advanced directive, a MOLST is indicated for people who are living with serious illness. Advanced directives are, just as Dr. Grimm said, because we're at a trauma center, we know it's young and fabulous people as well, that things can happen unexpectedly. So all adults, everybody 18 and older, we would encourage them to have at least thought about who would be their decision maker if they decide to do a healthcare proxy, so that they ensure that is the person that would be representing them. The time frame. So a MOLST, when that's done, those medical orders done, that is for the current care, meaning how are we going to care for this person now? Because again, as Dr. Grimm said, things change as you progress through your life and as you progress through an illness. So a MOLST gets updated, it gets reviewed and renewed. The clinicians look at it to make sure, does it still make sense medically in the context of what's happening with the person? Advanced directives are just what we said, that's planning for future care. So today, as I'm relatively healthy and relatively youngish, how would I want to be cared for versus, if something should happen and I were to become so ill or injured. So who completes the form? So a MOLST is done by a medical professional in New York State. It's a physician, a nurse practitioner, or a physician's assistant can complete them. And that's done after meaningful conversation with the person about what would be most important to them, so that we try to create this, what we call shared decision making, where the person is bringing their values, what matters to them, and then the health professionals can try to match and create a care plan that would support a person in living a meaningful life, and not receiving, again, unwanted care. Advanced directives are done by patients, and we'll talk a little bit about that. It doesn't need to be notarized. It doesn't need an attorney. You can go on the New York State Department of Health and pull off the forms and complete them with 2 adult witnesses over 18. And so that's their legal documents. Yes, the resulting form is obvious. After that, that's done. The most is done or an advanced directive. A healthcare agent or surrogate role for the most. If the patient loses their capacity, then we can go to the decision makers, because again, it's in current care, so things can change. So a person may have made a decision that I would not want to be resuscitated. In the event that I die, just allow me to die a natural death. However, if something happens suddenly and they need a surgery, let's say, the family could say, well, during the time of the surgery, we would want to rescind that order for the time. So do what's necessary during that time to get them through the surgery, and then we'll go back afterwards and see that. So it can change, is my point. Advanced directives cannot change, because those are done by you for the future care. Portability, we actually have the responsibility, because we create the MOLST in order to try to take care of that information so that we can access it and use it in a time when you would need it. The portability for advanced directives are yours. I personally keep my wallet-sized healthcare proxy in my wallet. So in the event something should happen to me, and my trick is I keep my insurance card tucked inside of it. So if something should happen and they're looking for my insurance card, they'll go through my healthcare proxy. And periodic review providers, we have the responsibility to review MOLSTs, and advanced directives are for you to see if things change in your life, people come and go, things happen, for you to think about and keep updated on, would you change your healthcare proxy, or would your care preferences change as your health and life changes. So this is just a very blurry snap of what a MOLST is. If folks aren't familiar with it, it's this very bright pink color, because what they are is they are actionable orders in the community, meaning that if something should happen, I'm so sick in my home that, and I have strong feelings about how I'd like to be cared for. I've had meaningful conversations with my doctor, and I've created these orders, and I'm so sick that I actually don't mind having this on my refrigerator or on my bedside table in the event that something should happen to me and an ambulance comes. Then the ambulance, the emergency technicians can act on these orders. So if it's important for me not to be taken to a hospital in the event that I become ill in my home, they are able to act on that and keep me in my home, and provide care to me there that would, be in accordance with this order. So that's the MOLST. And again, it's not for everyone. It's for folks who are experiencing a serious illness and have strong feelings about their care and have had meaningful conversations with their provider. So this is Dr. Gawande, and he wrote the book Being Mortal, as Dr. Grimm talked about, and we saw him a bit in the video with with Ellen Goodman. And if you've not had a chance to read Being Mortal, which was on the bestseller list for a very long time, he really talks about the medicalization of death and dying, how we've taken something that is a normal part of living, and really created a lot of regulation around it. So what he says, and to Dr. Grimm's point, and that is true when we talk to folks, people don't want to die, they want to live, but it's how they want to live that's important. And so he says our ultimate goal, after all, is not a good death, but a good life to the very end. And so I think that's it. If we, people who have had the lived experience of going through something with their loved ones, they generally come to these community events with us, stories. And that's really what makes it, is the more stories we share about those good lives that were lived until the end, helps us all continue to have these talks with the people around us, to help. Really, it really is about helping your family. So, oh yeah, so I want to share with you, if I could. Oh, we have lots of time. This is because we talk a lot about this idea of advanced directives, putting in writing what it is, how you would want to be cared for, which is so difficult. And as long as I've been here, I feel even at times more confused rather than less confused, because when you see a situation, as Dr. Grimm alluded, somebody who may have gone to an attorney, created a document that said, I would, not want to be cared for in this particular way if something should happen. And then they find themselves in a situation they never could have imagined. They never thought that it would be they were cleaning the gutter and fall off a ladder. They never imagined that. They thought they would have a big heart attack and die, or have a big stroke and never wake up. And so when they come in with these living wills, and it says, if I am in a terminal or irreversible condition from which there is no hope for recovery, I do not wish the following. And then we have a group of generally trauma surgeons and different folks saying, well, of course we can reverse this. Of course it's not terminal. But again, we have to think about, would this be a life worth living for the person if we could get them to that place where they would be nursing home dependent and not waking up? So one of the physicians that was involved in the original conversation project, her name is Dr. Karen Boudreau. She wrote a letter to her family, which I think the first time I read it, I thought this is really the best advanced directive I think that she could have given to her family. And although I didn't write it, I do keep a copy in my own wallet too, just in case, in the event that it would ever help my family if something should happen. So it's called Don't Panic, It's Okay. And I'd like to read it to you. So she says, don't panic, it's okay. If you're faced with a decision that you're not ready for, it's okay. I'll try to let you know what I would want for various circumstances, but if you come to something we haven't anticipated, it's okay. And if you come to a decision point and what you decide results in my death, it's okay. You don't need to worry that you've caused my death. You haven't. I will die because of my illness or my body failing or whatever. You don't need to feel responsible. Forgiveness is not required. But if you feel bad, responsible, guilty, first of all, don't. And second of all, you are loved and forgiven. If you're faced with a snap decision, don't panic. Choose comfort, choose home, choose less intervention, choose to be together at my side, holding my hand, singing, laughing, loving, celebrating, and carrying on. I will keep loving you and watching you and being proud of you. So she wrote that to her family, which I think is just, I think about all those families I stood alongside, if they'd had something like that to help guide them, how much better it might have been for them. So thank you for your time. I'm not sure if there are questions, Christine.
Thank you. I don't see any yet. We can give everybody a couple of seconds to kind of put some in. But in the meantime, I'd like to thank both you and Dr. Grimm for joining today, and thank all of our attendees for joining. There will also be a brief survey at the end of this. If you could take a minute to fill that out, we'd appreciate it. And I don't see any questions yet. So if people have questions, feel free to email me, or you guys have contact information that you could share with everyone?
Yes, we can share that. I apologize. We should have put it on a slide.
Okay, just verbally.
Yeah, so anybody that has questions, you can email. I'm going to share my email if that's all right. It's slauer, so SLAUER uer@ecmc.edu. And we're happy to take any questions you might have. And I can share Dr. Grimm's phone number. No, I'll give my phone number. My phone number is 551-7212. And oftentimes when we've gone into the community and people will contact us afterward, because life happens, even, we've had folks a couple times, they've come to a presentation and in a short time, they've found themselves in a circumstance that we were talking about. And so we're always happy to, support in any way that we can, offer more information and if, any guidance we can offer around what, palliative medicine is, about the services at ECMC or in the community, and certainly anything about advanced care planning or advanced directives.
Thank you again. And then I hope everyone who's joined today will join us again next Wednesday. Our topic will be landlord-tenant law in the year of 2020. Take care, ladies. Thank you.
All right. Thanks, Christine. Bye. Bye. Thank you.